Well, so it's a pleasure to be with you today. It is race month for Indiana, so getting closer to the Indy 500. I was reminded that the cold weather in May is good for the race. It means the cars will go just that much faster because of the thermodynamics of the car. But it is a cool May day, especially after we had such a wonderful early summer in April as well. But it's a pleasure to be with you. My name is Cody Mullen. As Ali said, I'm a clinical professor here and Center Associate Director for the Center for Rural and Migrant Health. And we're here to talk about telemedicine and behavioral health. This is the third of a three-part series. So we surveyed all the critical access hospitals last summer of what's the biggest needs you have, and behavioral health quickly rose to the top. So we did an intro to behavioral health in March. We then did a deep dive in interfacility transfers in April. And now here we are in May to talk about telemedicine and behavioral health and what that looks like. I would like to thank those on our team that have worked tirelessly on this presentation to help it get to where we are today for our discussion. Sue Hancock, who is a doctoral student on our team, and then Susan Grasham, who is our program manager on our team. And thank you to both of them. And then also a huge shout out to the Indiana Department of Health, State Office of Rural Health, and HRSA, Health Resources and Services Administration, and the funding through Flex that supported this work. Please be on the lookout. If you are at a critical access hospital, we will be redoing our survey here in the next week or two. So you should get that. We will have a special session in August, which is a pressing need, and then we'll be planning out the next year's sessions based on the survey results. So please give our team that information because we want these to be meaningful and useful to your team, either live in session or in the archived recording on the YouTube station that the Indiana Rural Health Association supports. And we thank them for their partnership and collaboration with us on that as well. So where are we going to go today? We have four main topics we're going to talk about. We're going to do a quick brief history of telebehavioral health and where we have been as a country going all the way back a while ago, a few centuries back. We're then going to talk about technology and setup considerations and things to consider if you're looking at going into telebehavioral health in different settings. We're going to talk very, very briefly about billing and loop you back to some resources, especially resources at the Upper Midwest Telehealth Resource Center, the UMTRC, which is an IHA-sponsored, HRSA-funded project that has expertise and specialization in telehealth and telebehavioral health as well, with some general ideas there. And then as an academic institution, we want to make sure we loop back and tell you what does the literature tell us about the efficacy and the acceptance and the adopting of behavioral health and what that looks like. As Ali mentioned, I have the Q&A and the chat open on my screen. So if questions come up as we go through, please feel free to put those in, and I will try to acknowledge those, or we'll have time at the end as well. So, a brief history about telebehavioral health. So, telebehavioral health goes all the way back into the 20th century. Telehealth has been around longer than we sometimes realize. It has roots all the way back to the American Civil War, when a 15,000-mile telegraph network transmitted medical supply orders and casualty lists. In 1876, Alexander Graham Bell invented the telephone, and didn't take healthcare providers long to figure out that they could use it to reduce office visits. In 1905, William Einthoven transmitted heart sounds from a hospital to his laboratory through the telephone. And in 1948, the first transmission of radiology images were transmitted between Westchester, Pennsylvania, and Philadelphia. And then in the 1950s, doctors in Montreal devised a trailblazing teleradiology system. So telebehavioral health and telehealth is not per se a new thing. It has been around for a while, but obviously technology over the last probably 15 to 20 years, heck, even the last 10 years, have really evolved the way that we look at telebehavioral health. We continue on the history. In 1959, the University of Nebraska was the first to use two-way video communication for telemedicine. In the 1970s, NASA put its space-age technology to use in the STARPAHC project, or the space technology applied to rural Papago Advanced Healthcare, which used microwave technology to link physicians in India health services to rural patients. And this technology had a worldwide humanitarian impact by getting emergency communication diseases after things like the earthquake in Mexico City in 1985, Armenia in the Soviet Union in 1988, Also in the 1980s, X-ray transmission became standard practice. Medical services expanded their reach to war zones, and correctional facilities used telehealth to reduce transportation to hospitals and needs. In the decade before and after the turn of the century, the internet, broadband, and the proliferation of personal computers, cell phones, digital wearables contributed to an environment where telehealth could thrive. And then there was the non-technological boosters of the COVID-19 pandemic, which hard to believe has been 6 years ago since initial cases. There's nearly universal agreement that the global pandemic fostered major advancements in the use of telehealth, and sometimes necessity indeed is still the mother of innovation. I know telebehavioral health was around before the pandemic, but quickly when the pandemic hit, we transitioned to that stay at home and we really said, what can technology do and how can we ensure not only our patients kept safe, but how do we ensure that our providers are also kept safe? So, what are some technologies and set of considerations when we're considering doing telebehavioral health, and what does that look like? So in your community, we always want to stop and say, what behavioral health services currently exist in your community or target population? What is the needs that you're looking at fulfilling? Maybe you're looking at providing telebehavioral health in the emergency department or the ED setting. That's a very different need than if you're looking to partner within schools and have telebehavioral health for the high school age children. So during their study hall, they can go to a spot, pardon me, in the high school and get that advanced services. Maybe you're looking to do geriatric telebehavioral health and you're partnering within nursing home settings or community-based individuals who would come into a clinic setting for that. Would your organization benefit from telebehavioral health services? And I think benefit is a big word that can mean a lot of different things. One is, what is the health access and the health quality that that would provide to your community? What's that benefit? What is the complication or the compilation of services that your health network is currently providing? How does telebehavioral health fit into that? Do you currently have zero behavioral health services? So this is a way to get into that space more easily than recruiting providers into your community, or are you still looking, or you are in that space and looking to expand, or is there a need hole currently that you're trying to backfill as well? And then what concerns or questions you have regarding your blah, blah, blah. What concerns or questions you have regarding implementation of a telebehavioral service? Again, as you're jumping into these things, this is a quick 30, 40-minute, 15-minute discussion this afternoon or this morning, depending what time zone you're in, to start the wheels turning, but having further discussions about what does this look like from a technology standpoint, what's this look like from a care pathway standpoint, what's this look like from a billing standpoint, what's this look like for our patients and our providers, and what are they looking at when they support these things. Again, reaching out to those resources. So my team here at Purdue is happy to have those discussions. The UMTRC, I know, is happy to have those discussions. There are several different groups around the state that are willing to have those conversations with you for free and really start to ask some probing questions. We don't need the answers back, but just things to consider as you're looking at those things as well. So what do you need to get started? What are the things that you need there? So first off, you need a location. Where do you plan to provide this service? Are you looking at it being from a home-based setting, which I don't have listed on here? So you're looking at people are going to be at their office or at their place of employment or at their home or somewhere else where they're going to be interacting as the patient with a provider that's also at home, or are they going to be in a clinic, or where are they going to be doing that? If you're looking at doing an ambulatory-based service where they're going to come into your clinic to receive these services, do you have efficient Wi-Fi? I know during the pandemic, early and even past the pandemic, Wi-Fi has been an issue at my home, but then also here at Purdue. About 50 feet that direction is a 300 student lecture hall. My Wi-Fi, I know when students are in class and when students are not in class. And if I'm involved in a telebehavioral health service as a patient or as a provider, a lag is not acceptable. So how do we upgrade that? Or do we have a separate network dedicated to only providing the telebehavioral health services? Do we have a welcoming environment? We'll talk about that in a minute. Or are we looking at more of a crisis type response for telebehavioral health? So we're going to have an individual that may come to the ED, they may have some physical health needs, but maybe they also have a behavioral health need. So do we use telebehavioral health to get a specialist in the behavioral health field quickly and immediately to engage with that patient, support that patient and that family? What type of cart will you have? And we'll talk about equipment in a minute. Jayco and American Well are kind of some standard ones, but there are several others out there. These are just examples who are technology agnostic, but just some examples of there. And then what is the device that you're going to use for this? Are you going to utilize a tablet, so a Surface or an iPad or an Android tablet that is self-contained, includes the camera, includes the Wi-Fi, includes an operating system that allows the software to be added on that? Or you're going to use a laptop or a computer or some sort of webcam system where you're going to have a peripheral that's going to be plugged in, and how's that going to look like? Or do you want it to be larger and use a television so that the patient can interact with that moving forward? So as we think of the equipment and what that equipment looks like, so this is an example of a Jayco cart that I know some hospitals in the state utilize. This is a way for an iPad in this example, but there are several different attachments for surfaces or other technology tools that you would like to connect to that cart. But an iPad is something that a lot of your employees are going to be comfortable using. They use an iPhone. They may not use an iPad on a daily basis, but they're going to be comfortable in that. So as you're incorporating that, so how are you going to make sure that everyone is trained, the clinical staff, the provider, and the clerical staff? So as the patient walks in and they need to be roomed for their visit, who's going to do that, and what's the protocol for that? Who's going to bring in the device and initiate the visit? Is the patient going to be given directions and they initiate themselves? Or when the device rolls in, is the provider on the other end, the distance site provider, are they already going to be present on there? How many devices do you need, and what do you expect your volume to be? You don't want patients to be waiting on a device. So if you're going to have multiple rooms being used at the same time, do you need a device per room, or do you need, 51% of the rooms will have a device, so you don't need to have all the devices? What's the backup plan if that device were to not work for whatever reason? Or what I'm always fearful whenever I do webinars, what happens when my software wants to do an update and I can't pause it? Do I have another device for doing that? So how do I do that? And then what are your protocols in place to ensure that device stays charged? So if you're using a tablet, it has a battery, or a laptop has a battery. But if I'm using a desktop, that's going to need a power outlet during all times. How do I prep it for the patient? How do I ensure that the device is secure? So the patient's not doing other items on that device, that the device is not intended to be done on that device. And then what's the upkeep, and how am I working within our IT department to ensure that patches and updates are being given to that? So as we look at patient experiences, there's different ways we think of these. So when we think of telebehavioral health, here's a couple pictures. I'll be honest, we took from the interwide web, the World Wide Web, Google, to really demonstrate what this could look like. But these are very clinical style engagements. So the patient is in a room. On the left side, you see that patient has that cart right in front of them. It feels like an exam room. You have the tile, you have the easy wipe down chairs. On the right side, you see that the patient still has that MA or CNA or whoever is helping to room the patient is present during the start or maybe during the whole visit, so they can be doing the physical pieces that are necessary. Notice there's another device in that room. So you have the device for check-in and check-out and access to the EMR, and then the telebehavioral unit is being utilized specifically for that purpose. So that provider is always there, so you're not minimizing or pausing the video for that support. We look further beyond that. Um, how do we make the environment a little more inviting, a little more comfortable? Especially if you're doing telebehavioral health, it may be appropriate and okay to be in something that's not as easy to clean like you would have in an exam room. So you have a couch with a light, so you have softer lighting. You have a larger TV present, so the provider is more real size than on a little 10 or 13 or 14-inch screen. You can have more sophisticated cameras in place because it's stationary. And now you're having a device per room. You also want to, sorry, wrong direction. You also want to work with your IT provider at your facility or at your telebehavioral health. What's the tool that you're going to use that's HIPAA compliant? Zoom can be HIPAA compliant. Teams can be HIPAA compliant. Your EMR, and I purposely found a picture that has a lot of EMRs, again, to be technology agnostic. But do they already have a module that you're already paying into that will work for these things? But how do I ensure that these are HIPAA compliant? How do I ensure that they're supported there? You also want to ensure that you have security. What's the device? If I'm leaving the patient alone with the device, how can I ensure that that patient is not able to get into the EMR system on their own and see protected data that they should not have access to? How do I work with my IT or my IS my departments to support that? The clinical team, how do I train them so when Zoom has an error or something goes wrong with us, the tool or Teams, they have steps to work through quickly and supported there. Ensuring that you can disable all the applications in the settings. On iPads, this is actually a parental lock. So you're parentally locking out the things that you don't want the patients to get into. I know that's not the way we want to frame that in our thought process. But again, how do I help the patient not change the Wi-Fi or change the setting or change the passcode? I think a lot of us have the horror stories, not that a patient would do this, of a child who gets a phone and next thing you know, it's in a different language. And then you're trying to borrow someone else's phone to work your way through to get back to the language menu to get back into English or the language that you can understand and prefer to see. But how do we lock down the devices and supporting all those things? And then how do we verify that that's still there every time we do an update, a patch, or support for that? And then lastly, how do we prepare the staff? We have varying ages and technology comfort with staff. All of our staff are probably using an EMR system, so they're not going to be totally anti-technology and not using technology. But how do I recognize some of those generational differences that may occur within my own staff about devices? And how do I ensure my training is rising everyone up to the same skill set and not assuming a base knowledge that may not be there? I recognize as a professor now that I teach students who are I won't say how much younger than me, but younger than me than I like to think sometimes. And their interaction with technology is very different than my interaction with technology, and their approach to that technology is very much from a casual interaction with technology, not from the professional side of things. So again, recognizing that across all generations. How do we develop step-by-step instructional manuals? It's very clear, screenshots, very, very systematic through the steps that we have to do. How do we make sure that we document what are the codes that we need to get in there, but then make sure that those codes are still secure? How do we evaluate ensure proper usage of the equipment, that it's being used the way we need it to be used, that if there is a barrier that comes up, that barrier is addressed? And then what's the timing? Is it a staff meeting? How do you do frequent check-ins with your team? Because again, this is a service that once patients get used to using it, especially if it's in the ED or in a crisis type setting, you don't want the provider or the clinical staff to be delayed of like, should we use this? Because we're not even sure how to use it. It's should we use it because of the clinical desires there as well. Okay, if you have questions, please be putting those into the Q&A window or the chat as well. So now as we talk about billing and how billing works, and billing is a superly complex, can be a whole discussion. And frankly, one that I just want to give some thoughts to, some things for you to think through, but really encourage you to reach out to other sources. So we have what we call the originating site. That's where the patient is at. Regulations change who and where those originating sites can be. During the pandemic, we saw a reduction or a relaxing of requirements. We've seen some of those things creep back in to regulation and law, but also some changes. Things are constantly changing. So again, as you're getting ready to launch this, I encourage you at that time, what are the current laws and regulations? Because even if you're looking at doing something 6 months from now or 3 months from now, the laws could change. I encourage you be reaching out to legal counsel, be reaching out to your resources. What is it right this second? And then making sure that we have a methodology to be notified if those change. So there is a fee there, a facility fee there, and then your specialist, your telebehavioral health provider, we'll talk about that in a minute of what that could be, is at a distant site. Again, things are changing. Is that distant site also their home and their individual dwelling? Are they required to be in some sort of clinical setting as well to be that distant site? Again, things to consider, talk through, understand. If they are allowed to be at home, what are the requirements for them to be at home? Do they have to have two different methodologies of internet connection? So a home connection through a fiber optic company and then a hotspot option on a cell phone. Do they need to be in a private room where the door's shut so there is no overhearing of the telebehavioral health appointment? Again, all things to consider. Again, at each individual payer, CMS is kind of our gold standard. Most of our private pays adopt that, but sometimes they don't. So making sure you understand your payment mix as well. Who is that provider? So in telebehavioral health, that can be a wide swath of individuals. That can be what we would consider as prescribers, so physicians and NPs and psychiatrists that are working in and supporting that patient from a medication management type perspective. But that could also be individuals who are involved more in cognitive-based therapy, CBT therapy, or other types of forms of talk therapy that doesn't have a pharmaceutical or pharmacological component to it. So that could be a PhD or PsyD, that could be an MSW or an LCSW. So again, understanding who are the providers that we need, what is the goal that we want to provide in this billing. So if they're coming in crisis, do you need a prescriber that can help do med management from the ED, or do you need someone that can help determine if they need to be inpatient or outpatient treatment? Maybe they're a provider at your referring network. Go back to the last webinar where we talked about interfacility transfers, so they're able to do all those things there. Or is it routine? And I mean routine with a loose terminology, but is that your scheduled weekly, biweekly, monthly therapeutic sessions that occur where there's discussion? And medication is not a component of that. That's being provided by that LCSW or the PsyD PhD as well. So a lot of things with distance site billing to keep in mind around the HCPCS codes and CPT codes. You want to make sure you add a place of service modifier for telehealth services. If you're under optional payment method 2, then you want to make sure you add your GT modifier. All these things, again, are constantly changing. Again, want you to just be thinking through if you're watching this recording later, you're listening live today. Again, there's some resources here. Happy to share the slides. We'll share our email at the end, but it's rural@purdue.edu. You can reach out. We'll share these slides. Links to different sources here. UMTRC is a great resource for our region. They support 4 states, but then also CMS have guidance, Indiana Medicaid and FSSA, OMPP have guidance as well. I also encourage you to be thinking through how could telebehavioral health work that's not a traditional therapy or traditional med management type appointment. What are some other styles of care as we look at more value-based care models? A model that's been out for a while now, since pre-pandemic, about 10 years now, is a collaborative care model where a primary care provider, a physician and PPA, is seeing that patient. There's a behavioral health need associated with that patient. So they referred over to a behavioral health care manager that's trained in that. And they're working closely with that patient between that treating billing patient there in the upper of the circle. That red on the left side is that behavioral health care manager, that patient in the middle. And then there's access, not necessarily directly by the patient, but between the primary care provider and that behavioral health care manager to a psychiatrist, a prescribing authority. So if there are psychotropic medications being prescribed by that primary care doctor, there is this behavioral health care manager that can help manage that, do additional visits that the PCP may not be able to do. And then if questions arise, all 3 of the parties involved, the patient, the treating provider, billing provider, and the behavioral health care manager, have a way to reach out to a psychiatrist, have an established relationship to really have a discussion with them and say, these are the side effects, or these are the things that are being addressed by the medication, but these are the gaps that we see with this medication as well. If we look at the collaborative care model, there's a lot of different codes here. So I put this slide up. This is a screenshot from a document linked at the bottom from CMS. Was screenshot a couple days ago, so as current as possible. But again, things are constantly changing as we see new physician fee schedules come out and other information around those. But COCM, CPTs have different codes based on how many hours that the behavioral health care manager, the billing practitioner, how much time we anticipate they're going to have in a month. Again, encourage you to work with your legal counsel, work with your billing department or consultants on those things. Have discussions. How do these things fit in addition to your traditional therapy appointments that may have a traditional code as well? Other things to keep in mind is if you're offering these things, what's some of the measurements? What are some of the things that you want to make sure you're documenting in that EMR system? I am not a clinician, but these are things that, as we talk to others and as I've been involved in behavioral health, behavioral telehealth for other projects and things that come up. 2 of the things that we'll just share is the PHQ-9 So this is a self-report on a scale of 0 to 3 on 9 questions. Top score is 27, bottom score is 0. Really looking at depression and the potential to have the depression present. GAD-7 is another thing to look at. This is for anxiety. I scanned this 0 to 3 scale, but a 7 metric or 7 item instrument, so a score of 21. And we can see on both of those, 0 to 5 or 0 to 4, depending on the score, is none, mild, moderate, moderately severe, and severe, with recommendations of what those could be. So maybe this is a way for your primary care office to do some initial analysis. I know a lot of providers are already using the PHQ-9, but then what are the workflows within the EMR system? Say, okay, this patient scored a moderate score here of a 12 on the PHQ-9 and a 12 on the GAD-7. We really should be considering some CBT and some pharmacotherapy. So what's my telebehavioral health? What's my referral pathway? Is that something that can be done during the same patient appointment? Hey, sir, madam, do you have time during this appointment for me to bring in a behavioral health care specialist, talk to you during this appointment? Or can we give a referral where they can then come back to that same clinical setting or do it from home? Have those discussions. So things to be thinking about as well. If we think back and we go all the way back to, I say all the way back, but 2020, so some of this data is a little bit older. But if we think, what is the prevalence of these things? So if we look at the substance use disorder, which is an area of mental health, roughly 14.5 million people, 14.5%, sorry, 40.3 million individuals aged 12 or older had a substance use disorder diagnosis. Roughly 21% of the population 18 or older had a mental illness, for 52.8 million, and about 6.7% of the overall population, or about 8.2 million individuals 18 or older, had a co-occurrence of both that substance use disorder, that SUD, with that mental illness. So there is a large percentage of our population, a significant percentage, maybe not large, but a significant percentage of our population that need support, medication, talk therapy, but formalized support for these things as well. If we go back all the way to 2016, we can see that a lot of these data points have nearly doubled in the 4 years from 2016 to 2020. I have not seen new data in 2024, and I think the pandemic caused some of those things as well. SBIRT, screening, brief intervention, referral to treatment is another approach that these are a lot of different screening forms that can be used for different substance uses as well. So the audit, for example, is alcoholism. We have alcohol screening and different interventions. So again, different areas as you're looking at how do we design telebehavioral health services. Not only do we think of our mild depressed, mild anxiety, we also have our serious mental illness, SMIs, patient population to design for, and then also our SUD, OUD population to design for as well. And our protocols may be different, our treatment approaches may be different, but telebehavioral health is going to be able to really address some of those things. So what does the literature tell us about all these things? So considerations, but like what are the actual outcomes associated with it? So there are 6 studies, and I'm not sure we can get through all of them today. I had them all here. We can share the slides with you. I'm going to talk to about 12:45, 12:48, and then I want to make sure we have time for questions and answers as well. And also to make sure you have time to transition during the lunch hour to that. But so far today, we have 3 systematic reviews, which are looking at synthesizing multiple studies together to share with you. 2 are focusing on telehealth in the emergency department, where mental health patients often present. And 1 was specific to those who are deployed in military services and how they use that. We also have identified 3 smaller studies to share on the use of telehealth to reduce cancellations for behavioral health appointments and the diversion of non-emergent patients from overcrowded emergency departments and emergency medical services. And then our final study, if we have time today, will focus on the usage of telehealth in community mental health centers, or CMHCs. So the first study for us to talk about is telemedicine in the ED, an overview of systematic reviews. This was done in 2022. The primary question of the studies were, is telemedicine or technology feasible for the emergency department? What are the benefits of the application? What challenges arise? 18 studies met their criteria for inclusion, which means they were published between 2015 and 2020. So all this data is going to be pre-pandemic data. They were published in English, were included, they were systematic reviews, and that they were focusing on the ED. Results are looking at what were the benefits of telemedicine in the ED and what were challenges there. So we looked at 9 identified real-time video conferencing as the most feasible technology. Forward in store is here. This is an asynchronous method where the patient comes in, you are going to interact with the patient, you're going to store that data and then share it to the provider to be reviewed at a later time. It's not a real live interaction between the patient, the provider there at the site of the ED, and then the provider that's being consulted in. So 9 of them really looked at that real-time video conferencing. And if we think back again to how old the study is, or the studies that were used for this 2015 to 2020, Teams was not a big thing. Zoom was starting to become a bigger thing, but was not as big of a thing. One study looked at using just audio conferencing, so good old telephonic conferencing. One study looked at telemonitoring, and then 3 were that forward in store, which is not that real-time analysis. This table here summarizes the finding of the 18 studies. 8 of the 18 studies found that cost reduction was found in related to telehealth implementations, so that is a benefit. 7 of the studies found improved quality of care. 6 found a decreased patient transfer rate from rural centers to major centers. So how do we keep that patient in the rural community around their natural supports, around the supports there, but then also how do we ensure that our facilities are able to bill for those services? And then you can see 5 of the 18 studies looked at reduced mortality, treatment time, time, brief contact, and cost effectiveness. Excuse me about that. So what were some of the challenges? Not surprisingly, the largest number of studies identified technological issues and difficulties as the challenge. The technology is going to need to work when it needs to work, and the staff doesn't have time to troubleshoot, especially if they're in a busy ED. You have a lot of patients coming in, or you have a patient in crisis, so you need that immediate interaction. So that's an issue. 5 of the states found legislative, ethical, and policy issues as an area of focus. Again, how I mentioned, make sure you're working with your billing department, your legal counsel, and ensuring all these things are in place. 3 of the studies found jointly protecting patient privacy, prolonged consultation time, scarce limited literature on technology implications as limitations. You can see some of the other limitations there. And here are more challenges that different studies, 7 of them were found by just one of the studies to be considered. All 18 studies were evaluated for risk of bias. 4 studies conclude that telehealth in the ED was feasible, but 3 of the 4 have a high risk of bias. One study with a low risk of bias concluded that it was not feasible. The majority of studies, or 12, conclude that telehealth had a high potential, but more evidence was needed. And we've seen, I think this is pre-pandemic, so during the pandemic, we had a lot of data sets a lot of data that was collected. And 7 of those studies had a high rate of bias. Something to keep in mind is that all these studies included were before the pandemic existed. So a more recent review focused on the overcrowding of EDs globally. This study was published last year in 2025. 4 factors contributed to overcrowding in the ED, and these were aging populations or longer lifespans, increased prevalence of chronic disease, patients that don't require emergent care, and misdiagnosis of patients. Authors make the case that overcrowding EDs have not been solved by building new ones or increasing beds, and that opportunity costs arise when EDs treat patients that don't need immediate life-saving treatment. So an opportunity cost, as a patient comes in, if I only have 14 or 16 exam beds, maybe I only have 8 exam beds, if I'm using an exam bed for a behavioral health patient, and then I have a physical health patient that comes in that needs immediate intervention and that exam bed is not available, that could cause for concerns there and opportunity costs associated with that as well. So, as you know, overcrowding EDs result in an adverse consequence for patient and providers, plus it poses a threat to the entire system. So we see that patient outcomes have protracted wait times, delayed treatments, and higher morbidity. Providers had exacerbated staff shortages or that bed block that we just talked about, that reduced ability to provide quality of care, contribute to burnout. And then at the system level, these issues undermine sustainability and reliance of acute healthcare delivery. We recognize that our EVs are being used a lot more a lot more, and we need that capacity. So, what efforts do various telehealth strategies have on ED demand? So, the studies that were included involved ED patients, those diverted from the ED, where interventions focused on telehealth strategies aimed at reducing EDs and involved any healthcare context exclusion criteria here, but they actually found 45 studies to be included from 2019 to 2014 or 2024, pardon me. So we had the a little bit pre-pandemic, but really included a lot of period during the pandemic. Several studies were done both outside the U.S. And then those that were done within the U.S. So, and what did we find? So 33 of the 45 studies reported decreased demand after telehealth implementation. So the ED overutilization and boarding and bedding issues were reduced in the majority of the studies. Four studies reported increased demand post implementation. So a little bit of the inverse, but still 33 saw that reduction. Six studies found no effect, and two were dismissed because of the low sample size. So if you're thinking of implementing a tele-emergency ED program, what does that look like? So what are some of the strategies that these authors found? Triage is the most common use, facilitation of that initial assessment, figuring out what is the appropriate pathway. Do they need to go in the ED, or is there a behavioral health telehealth room that they can be moved into that's more appropriate level of care for them? Keeps your physical health ED moving, also maybe quieter and calmer for the patient, which if they're in a behavioral health situation and or crisis, may be better suited for them. What is the follow-up of that patient? So that remote monitoring of the patient recovery and early intervention. What's the monitoring of the patient condition, timely intervention upon deterioration? So, as they're in the ED, how do we escalate that care if necessary or as identified? Diagnostics is remote clinical assessment and treatment planning, and then other areas of rehabilitation management, prevention of unnecessary ED transfers, and things of the sorts. So the study was characterized. Here's the table one illustrates the impact of telehealth on triage and follow-up functions as compared to monitoring, diagnostics, and other functions. Among the delivery methods, the synchronous have by far the greatest impact compared to asynchronous and remote patient monitoring. So again, telehealth is a great tool for the patient who needs that immediate interaction, and they can do so live. And instead of the provider walking in the physical flesh, they're on a virtual screen, and we're seeing that across all studies there. We looked at studies also report enablers and barriers to health implementation. So things to consider as you're looking at implementing this at your facility. These were categorized into four areas: the patient barriers, the provider barriers, and enablers, technology, and policy. 15 studies providers is the most important enabler. So providers were on board, it was there, and 14 studies identified the patient as a most prominent barrier. So what do those look like here? So as we look at the patient, what were their enablers? So is their technology literacy, is the support of caregivers, is a particular medical condition that they're being seen for, or on the barrier side, technology literacy was a barrier for patients. The complexity of the condition was a barrier for patients. Patients were reluctant or difficult in retention and poor home environment for providers. So the things that you as administrators are able to really address is, we want to make sure that they're enabling them by training them, by ensuring they have clinical expertise and that technology is adaptable. But what were the barriers? Well, if they were not if they're inadequately trained, if they did not have the training to feel comfortable to use that, and then just overall reluctancy. This is a new technology. If we go back to 2010 and the implementation of EMR, there was reluctancy about technology there. Technology, we want to make sure that works. So what were the enablers there? The use of existing digital systems. So if it's Teams, a lot of clinicians, a lot of providers already know how to use that. So that's easy to do there. Use of widely available consumer technologies. So things that we're using doesn't have a lot of unique steps associated with that. And we want to make sure that that internet is reliable, that when I click go or call or connect, it's going to go through and it's going to go through in a smooth way. Barriers in technology is the complexity of monitoring equipment. If we have telehealth specific carts that are very unique in how they're utilizing, that creates barriers if it's not a common technology. Connectivity issues, if I hit connect and it does not connect, and I have a patient, especially if I'm in an ED who's in semi-crisis or in full-on crisis, that creates difficulty. And then the inability to conduct full physical examinations. Telebehavioral health is nice because it's not a subspecialty of medicine where hands on the body are necessary all the time, so it's an easy way for that. But you can imagine for other telehealth connections where it is important to palpate the belly or look in the eye or listen to the heart. Technology can create a barrier of that when I cannot lay hands physically on the patient. And then policy, so regulatory approval and financial support are enablers. But what are the barriers? Not surprisingly, stringent regulatory restrictions and lack of government subsidies as well. So making sure that we have the policies in there. So our summaries or recommendations from this are providers and policy factors are the most important enablers, and patient factors are the most critical barriers. So as we're designing this and rolling this out, how do we ensure that our providers and our policy factors are taken care of, and then how are we going to overcome some of those barriers that we see within our patient factors and other things. So author recommendations for implementation. So what they saw, ensure that you have a comprehensive provider training, assess existing regulatory frameworks and the financial support, consider EMR compatibility and internet infrastructure, prioritize user-friendly design and clear patient communication, and then target high-impact use cases for that telebehavioral health, especially chronic disease management and mental health conditions. So as we think through of other different ways that this technology can be utilized, we're recognizing that we're having a lot it feels like, at least to me, increased mass casualty events or other events occurring due to natural disasters and weather. I think Indiana's already had more tornadoes this year than we've had the last 2 years combined. We're seeing higher rates of other traumatic events occurring, some man-made, some natural-made. So telehealth treatment for mental health issues are particularly important, and this study really looked at the importance for military personnel who experience delays or disruption in treatments related to deployment. Telehealth provides greater flexibility, reducing stigma. And we really haven't discussed that, but we recognize that there is a stigma associated with mental health, differently than we see in physical health. So going into a clinic that no one knows is it physical health, dental care, or mental health, that stigma is removed. Where if we know that that is the mental health clinic, and I drive by and I see someone's vehicle that I recognize, there could be a stigma associated with that or seeing them walking in and out. We also want to make sure in DoD or DoW space, it doesn't compromise security requirements. So in preparation for policy revisions, the Department of Defense at the time this was running out, Department of War commissioned a short suspense or rapid review of evidence published in the literature. They're most interested in synchronous video teleconference modes since it most closely resembled in-person treatment interaction. So how do we support those things? So what were the research questions and study aims is to evaluate the effectiveness of synchronous behavioral health care treatment delivered via telehealth compared to in-person care, and determine whether patients benefit more from a specific modality. So what methods? So our questions there are evidence-based behavioral healthcare interventions delivered via telehealth platforms as effective as in-person delivery for these treatments for a range of behavioral health care? And is there any evidence to indicate whether telehealth treatment modalities are more appropriate for some patients and inpatient care than others? So they looked at literature, they excluded literature, they included synchronous psychology or psychiatry and real time. They excluded all the asynchronous. So they found 999 studies, of which they included 22. More than half conducted with veterans, so not necessarily active service, but veterans, and primarily for post-traumatic stress disorder, PTSD, was the majority area. So again, as you're looking at what's the service, as VAs are harder and harder to get to. I know my father Monday had to drive to Indianapolis, an hour from Lafayette, to see the VA. The wait time for that appointment was long. How can we provide services to those who served our country valiantly and supported our activities abroad, domestically and abroad? Majority of the studies looked at clinical outcomes, and they found that telehealth and in-person treatment were very similar. Some were non-inferior trials, and 7 concluded that telehealth was as good as. So happy to have discussions as we get into the methodology of what that looks like, and non-inferiority trials versus other trial study designs. And several studies looked at depression and found that telehealth had better outcome than in-person care. Care was received their satisfaction, therapeutic alliance, and discontinuation for telehealth were similar. So we didn't see the negative outcomes increase, but it was not suitable for all patients. Those with severe symptoms and comorbidities did worse than telehealth and inpatient. Telehealth is not the golden parachute, golden bullet, whatever vernacular you want to use that will address all these things. It is designed for a specific type of patient, and that may vary for you as a provider associated with that. Telehealth provided, uh, uh, telehealth gives active duty personnel an opportunity to continue with treatment while deployed. It was cost savings and cost effective in the delivery of care associated with that. So I'm going to have time. Again, we had a lot of slides here. We weren't sure. So I have time for one of our individual studies that we looked at. And then we'll have questions and answers and give you a few minutes back as well. So we'll be done a little bit before 9. So recognizing that EMS and hospital EDs were increasingly burdened by patients with non-emergent healthcare needs, the city of Houston created a program including telehealth, social service, and alternative transportation to divert patients calling 911 to appropriate providers. The ETHAN program, or the Emergency Telehealth and Navigation, has 3 components: telehealth capacities between the paramedic, the patient, and an EMS physician, patient navigation scheduling to contracted safety net clinics, taxi transportation, social services follow up post incident. It works like this: EMS responds to patient call and assists them on arrival. If their condition is non-emergent, they are offered a consult with an emergency physician via electronic tablet, and other arrangements are made by their care to clinic visit that day or next day via taxi. I recognize that this is an urban intervention, but as you look at the GROW initiative here in the state of Indiana, I know our Region 3, our meeting is later tomorrow, but as we're thinking of interventions not only in years 1 and 2, but in future years, is this a type of program that your region can implement through mobile integrated health or other technology approaches for that? So what was the study objective? To compare the effectiveness of an alternative EMS telehealth delivery method relative to traditional EMS in a large urban setting. This is a case control design in which cases that opted to the Ethan match with controls that receive standard of care. We have their inclusion criteria here. Exclusion were individuals that had urgent issues or chest pains or other things that were physical health of nature. They were excluded from the study. 57 or 5,500 patients, pardon me, 5,570 patients participated in the intervention program during the period. 56% decrease in transport to the ED. Median EMS response time for the Ethan patients is 39 minutes. Median EMS response time for the non-Ethan patients were 83 minutes, or a 53% reduction. Follow-up on patient satisfaction was not significant, so we can say that the patient satisfaction was consistent or similar between the 2 interventions. New Indiana law, we talked about this in our last webinar, but just as a reminder, a new Indiana law that went into effect July 1st of last year that expands the patient delivery options of EMS transport. Instead of transporting only to hospitals and healthcare facilities, they can now take the patient to mental health facilities and urgent care centers. EMS organizations are required to have an advanced agreement with the new destination that establishes patient sustainability criteria and procedures and handling patient refusals, redirect transports, and facility hours. Transportations can be reimbursed for these transports and have protections under the law if they are acting in good faith. Leveraging this law could be an advantage to hospital EDs as well as EMS in our community. So as you recognize those different areas, again, happy to share this study with you as well, but how do you creatively use telehealth? We want to show these as examples, but telehealth can be used in so many different ways. And sometimes you think of it very much as a single track solution, but technology is getting better. I mean, my phone, a lot of our phones in our pocket have everything we need for the technology. So even if the patient's in a clinic and they're technology enabled, right, maybe we connect them using their own device as well. So with that, I want to say thank you. Again, we're happy to share these slides with you. We're happy to answer questions. We're happy to have discussions. We're happy to share all the slides that we didn't have time to go over as well. If you're thinking about implementing a program like this, we're happy to be a resource to you as I know the UMTRC and others around the state. So with that, thank you. Our email is rural@purdue.edu. That goes to Susan, Sue, and I. We all check that on a regular basis. Susan and I do for sure, but also my personal email is on here, cjmullen@purdue.edu. Happy to share those things. And with that, if there are questions, we ask that you please put those into the Q&A or the chat. You can also use that raise hand feature and we can allow you to speak. And
And I'm not seeing any other questions. So I think you covered everything great, Cody. Thank you for your presentation today. And yeah.
Thank you, and thank you all, and have a wonderful summer.